This is the Neurosurgery Podcast.
Welcome back to the Neurosurgery Podcast. We are on the opposite side of the state from Buffalo, here in New York City, Central Park. We're here with Elad Levy, chair at Buffalo.
Thanks for having me.
Thanks for coming back on the podcast. I wanted to touch on something maybe people don't prepare for, think about, especially if you're younger now, which is this whole process of how folks become trained, certified, whatever you call it, in endovascular. I'm going to call it brain work for now, not neurosurgery yet. Okay, tell me about the different tracks and how this works out.
Well, for people that are interested in cerebrovascular, you have to do endovascular, because if you like aneurysms, 80% of aneurysms are endovascular. If you like AVMs, you're gluing them. We're entering a whole new world of venous pathology, whether you're putting in brain-computer interfaces, transvenous, whether you're doing that e-shunt, shunting now through transvenous.
Yeah. Shout out to Carl Hallman and his e-shunt.
E-shunt. It's the whole world now. Venous pathology is brand new. And then obviously stroke. If you want to make an impact, you're talking about 1 million new stroke and TIAs every year. And now carotids, right? After the new trial, after CREST-2, carotid stenting is sort of the way to go. So you have to train. So if you're a neurosurgeon, we've made the pathway very easy. You can do your first year, your angio year, your basic year, enfolded in the residency. So instead of a 2-year fellowship, it's a 1-year post-grad fellowship.
Okay, so let's recap for the folks listening. So most neurosurgery residencies are 7 years, although there have been some in the past as short as 5, but mostly 7, maybe some 6. And then you're saying that one of those 7 years can be used to satisfy one of the endovascular years.
Correct. So the ABNS, or basically you have to have the endovascular intervention year has to be post-grad. The angio year, the first year of it, you can do as a resident.
How does that stack up against 6+1 programs where they do 7 years of residency, but the last year is like a transition to practice or fellowship year? That doesn't count?
You actually have had to have graduated.
Okay.
And they're holding firm, which is not a bad thing, because you want to be able to kind of have really great ICU care. You want to have the judgment. Do I do surgery? Do I do endovascular? So it's actually a good thing. I was a guy who actually did both enfolded. I was one of the first to do both years enfolded, and I'll tell you, in retrospect, I think I would have gotten more out of that second year had I already had a chief year under my belt. Okay, so now, in the US, you're saying neurosurgeons do a minimum of 8 years, essentially, right? Minimum, to get endovascular trained. So let's talk about the other, I don't want to call them competitive specialties, but we are the neurosurgery podcast. We're not the neurology or radiology podcast. So let's say you're a radiologist, because I've heard that a lot of folks who didn't match in neurosurgery, they're going to say, okay, fine, I got it. I'm not going to be a neurosurgeon. I'm going to instead do either neurology or radiology and then do endovascular work, right? What do those tracks look like? Yeah, they're actually not that much shorter. And since we are neurosurgeons, there's no question we're the best trained, because we're using our hands for 7 years.
Yeah.
So neurology has to do the neurology, then they have to do a stroke neurology fellowship.
Right.
And then from there they go into sort of that 2-year endovascular. So maybe they shave a year, maybe.
So neurology's 5 years? It's intern then 4 or intern and 3?
Yeah, it depends on, I think it may be intern, I'm not sure.
Okay, and then they do the stroke, which is at least a year.
Fellowship, at least a year.
And then another fellowship.
And then another 2 years of endo.
So 3 years on top of basic neurology.
Correct. So it's not that much less.
Yeah, and we're doing a lot more hours in training probably to be perfectly honest, in the hospital, right? We're on boots on the ground more.
And from day one, you're using it, whether you're doing microdisc through a tube, whether you're splitting a fissure, whether you're under the microscope, you're getting that tactile, you're getting that coordination, where for the first time for neurologists, it would be year 6 or year 7 or year 8 when they're touching a catheter for the first time.
And let's talk about radiology now. So you go the radiology route, they do like a transitional intern year, right? And then they do 3 or 4 years of radiology.
And then they'll have to do neuro. They'll have to probably do a dedicated year depending on neuroradiology, and then the 2 years, then neuroangio, and then neurointervention. So that's another potential 3 years on top of that.
So still 7, 8 years.
Yeah, there's no
shortcuts.
So if you want to be good at this, do it through neurosurgery. You have to do it through neurosurgery because you're trained to be a surgeon.
But let me offer a message of hope too, because JP and I have been doing this for a number of years, and a lot of our listeners, they're trying to find out how to find their place in the world, and they want to be part of this tribe. We had the most unprecedented year of of non-matching, the lowest matching rate in a long time this year, right? It was pretty high.
Yeah.
And we covered that with
like, what, 58%, 52%, something
yeah,
like that?
so maybe 4 out of 10 people didn't match who applied to neurosurgery. And a lot of those folks I know personally, because we helped them, went into radiology neurology. Do you train these folks in your fellowship?
We have. So I'm going to give a shout out to Max Mokin, who's in the Department of Neurosurgery at Tampa.
Okay.
With Harry Van Light. He was fantastic. He was a neurologist, and we trained him, and we trained one other who've done amazingly well. And I think these are sort of exceptions. They had the surgeon mentality. So if you go that route, that's great if you don't have another option. If you have choices, of course, we'd prefer you to go the neurosurgery route. But there are some exceptional interventional neurologists that are out there.
Yeah, for whatever reason, some people don't make the cut for residency, but they're going to end up being amazing. People always ask me, is it better to go to orthopedic or neuro spine surgery? I'm like, it depends on the person, right? There's good and bad in both camps, although we like to think our quality standards and variants are at a different level. I'm sure you do at Buffalo. But okay, so...
And that's a great point you make. So how do you standardize that? So the board... The ABNS created what's called RFP, Request for Focused Practice. So and that was a project I worked on when I was on the board with Howard Renna, and others, and Fred Meyer. So whether you come from radiology, neurology, or neurosurgery, there are metrics that you have to meet, and the 3 boards agree that you are certified. You get a request for focused practice in neurointerventional surgery or endovascular neurosurgery or endovascular neuro, whatever you want to call it, but we all share the same standards.
You know, so many of the folks I know in the endo world, my good friend Philippe Albuquerque, everybody went to Buffalo, right? You went to Buffalo, right? And then now you've taken over for Nick Hopkins, who really helped to carve this subspecialty that we're in, or you're in. Folks that are in endovascular have not been to Buffalo. They should visit, right?
They should visit.
Tell us about what you have there, the Mecca.
So a little thing, what we do different. So we can talk about we're the busiest stroke center and we have the entire market share, but what we do differently is 90% of our elective interventions are under conscious sedation. So flow diversion, intrasaccular, carotid stenting. We do them awake because honestly, it's a lot of volume and we've sort of honed that. And we do them outpatient. These patients go home the same day. So healthy patients with straightforward anatomy, they're done in the outpatient neurosurgery center under awake conditions and they go home. So it's a very different model.
But maybe it's mundane for you, but your major center, the one that everybody talks about,
we are
the Mecca.
Center.
It's a palace endovascular, is it not?
We are running many clinical trials. I think Adnan Siddiqui runs our clinical trials program. We have about 50 clinical trials running. We have the Jacobs Innovation Center. So you have innovation, trials, substrate, and we have 2 full-time medical editors. So they help the residents and the fellows publish between 80 to 100 papers a year.
It's okay. Well, Elad, I want to thank you. Elad Levy, Chair at Buffalo, former CNS president, true leader, great mensch.
Great friend of yours.
Yeah, and go Bills, right?
Go Bills.
Go Bills.